The program will begin with a presentation, and we will have question and answer sessions throughout the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and click Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You will receive an email within a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit feedback or any additional questions at that time. This email will not include the presentation. Now, it is my pleasure to introduce today's speakers. Ray Hirschman is the President and CEO of XG Health. Ray has several years of experience working with bundled payments and is widely known for his leadership experience in information and technology to enable organizational change in healthcare. Francois DeBront is the Executive Director of HDI3. Francois has an extensive experience working with bundled payments. HDI3 is a market leader in combining healthcare quality with evidence-based incentive programs for payment reform. Catherine Hayes Hollowell is the Principal of Bundled Payments at XG Health. Over the past 3 years, Catherine has worked with more than 37 organizations on Model 2 of Medicare Bundled Payment for Care Improvement, or BPCI initiatives, serving as a CMS liaison. In this role, Catherine has helped implement care redesign initiatives, leveraging Geisinger's proven care methods and XG Health's analytics and evaluations. It is now my pleasure to turn the floor over to Ray to begin today's presentation.
Good afternoon. Appreciate everybody joining our webcast today. And the title of our presentation is Beyond the Math of Bundles, Redesigning Care, Establishing Convention and Consistency. And the quick agenda review, we're going to talk a bit about the current market landscape and not only how we got to where we are today, but a bit of a forecast of what's in store for us over the next several years. Catherine's going to focus in on the importance of care redesign and value reengineering. Francois is going to talk about the importance of alignment of economic incentives, clinical quality, and patient experience objectives into the programs that we're in the process of deploying. And then we'll wrap up with a bit of a discussion around balancing your organization's preparation and for consideration of what you can do internally versus getting help from third parties. So the market landscape, as folks know, there's really no turning back on value-based payment. There's more and more providers are beginning to enter into risk-based contracts. They're primarily of two forms. One is for a population of people and a focus on the overall total cost of care. And the second modality of value-based reimbursement focus on episodes of care and bundle payment. There are, also ongoing kind of tried and true approaches for trying to contain healthcare costs and reducing reimbursement, in return for market share. The states are becoming major players. The states, several states around the country are using both their employees as well as the Medicaid programs that they sponsor as a way to drive and accelerate the adoption of bundle payment and value-based reimbursement. Medicare Advantage plans are beginning to see a squeeze on their margins, and there's an uptick in Medicare Advantage plans also wrapping into their contracting strategy, bundle payments. And the bottom line is that providers are going to be in a position where they're going to have to figure out how to lower cost and improve quality of care in order to survive this trend. We've got two kind of macro vectors of change that are happening simultaneously. One is in the area of insurance coverage transformation, and the other is in care delivery and reimbursement transformation. One is trying to get everybody to have coverage, and the other is really the vector that's going to focus on improving the affordability of care. And so we've seen before 2014 a fair amount of activity on the insurance side of the introduction of private insurance exchanges, states beginning to move towards rationalizing their strategies for how to provide affordable care to both their employees and through their Medicaid programs. And at the same time, there was a ton of innovation going around with the introduction and the proof of concepts around patient-centered medical homes, early movers on bundle payment. Geisinger was known, this is going on 8 years ago now, of being the first to really put a warranty tied directly to a bundle payment for a specific episode of care. There was the hatching of what we now call accountable care organizations, which are PHOs and whatever we called them in the past is just a reinvention of the same idea of a delivery system that is going to accept contractual accountability for a population of people. And we also saw just a real acceleration in adoption of EHRs and HIEs and at the same time shared savings and pay for performance programs. Where we're at today in timing is in this implementation and adoption phase. We have public exchanges pop, we have private exchange adoption really accelerate, and there's a number of different players out there that are seeing significant increase in the participation of private exchanges with increased amount of participation in those exchanges through fully insured products, not just self-funded arrangements. And we've seen a bit of an uptick in transparency and availability of information regarding cost and quality, although we're kind of in that nascent stage there. And what's happened simultaneously as the insurance market has begun to evolve is we've really seen a major push towards an acceleration towards value-based reimbursement and moving away from volume to value-based. It's still a form of fee-for-service, but the unit of service is the episode, and it's not the pieces or parts that go into these episodes. And we've also seen a pretty significant emergence of new enablers and intermediaries that are making these value-based reimbursements arrangements possible, bringing capabilities and technology and analytics that both the carriers and the providers historically have not had available to them to help accelerate adoption. Where we're going in the future is going to be towards a lot more localized choice on the insurance side. There'll be a bit more level playing field as far as competition for covered lives, and hopefully the regulatory refinements will make the market easier to participate in. I think on the reimbursement side, forward-looking is that we'll see an increasing array of collaborative care models. Consolidation and rolling up of all the providers is not going to be the only way in which these models will prevail. We're seeing a lot of emergence of really promising collaborative care models. I think once bundle payment becomes more established, the idea of transparency and the ability for a buyer to really understand what the price and the quality and the patient experience is for what they're buying prospectively is going to emerge with pretty significant impact on how the market will function going forward. These two are going to converge in that we will begin to see insurance products that incorporate into the benefit design the structure and the concepts of bundle payment, whether it's through reference pricing or whether cost sharing will be based on the bundle of service, not the professional fees, the hospital fees, the way things are structured today. And we also see a titration or a rationalization of provider networks. So the convergence of the levers that will address cost will get expressed in the form of insurance coverage and how people have access to that care. The final piece here is, so, what's the plan? What's the problem we're all solving for? And I think people are familiar with this, but we've been buying healthcare by the parts here. And it's just inherent in buying it this way is it drives higher costs. I know people have been talking about quality for a long time, but even today when you look at the defect rate, how much of care does not comply with the evidence, it's really almost an afterthought until the economics line up with the incentives to improve the cost and the quality. we will not solve this affordability problem. And again, we talked about the transparency being, in the nascent stage here, but once we have the definition of episodes and a way for people to understand that in the context of their benefits and how they're buying healthcare, I think we'll see a big improvement in informed consumerism. So the question is what comes first, the chicken or the egg? And I think we have the answer before us, which is if the reimbursement doesn't change, then you don't get the care redesign and realize the potential of the market. And we know now, based on the government making their changes towards bundle payment and the commercial insurance world, really becoming much more pronounced and clear about their desire to get to value-based reimbursement, folks are starting to get scared. They're getting chicken, and we're going to start doing some redesign. And so the answer is that the chicken comes first. And so we've lived through, the cost shifting and the strategy of consumerism and pushing more cost and skin in the game onto the patient without real transparency. The providers have dealt with years of compression and pushing down of unit prices. The third option that we're going to talk about today is really moving towards bundle payment, which is the intersection of how we pay for healthcare and the redesign that is required for this to become sustainable. So with that, I think we know that we got Medicare moving, we've got commercial bundle payment starting to become pervasive in many markets, and the state pilots, whether it's Ohio, New York, Arkansas, there's becoming a significant body of energy around the states becoming the real drivers of accelerating innovation in this space. I think we're going to take a quick break right here and ask some questions if there's any, and then we'll go into the redesign area that Catherine's to cover.
Thank you, Ray. We have a question from the audience. Most of the physicians are currently on work RVUs. How does value-based payment affect the physician reimbursement, and how does this translate to the current work RVU-based model for physician payment?
So I believe RVUs will still be around. They're not going to go away, but the RVUs are going to be components or elements that go into a overall bundle. And so there's a number of organizations that have been realigning where there's going to be a hybrid of how provider performance is evaluated. Part of it's going to be based on RVUs, and part of it's going to be based on quality and the overall performance of the bundle. So I don't think that it's going to go away. It's just going to be a hybrid of both the productivity or the volume of services a provider delivers, but in the context of a bundle.
Thanks, Ray. Here's another question from our audience. Who leads the Proven Care team, and how is the clinical champion selected?
So I can cover that, Ray, if you'd like. This is Catherine. So with the Proven Care team, the selection of the clinical leader is primarily done based on any clinician within the department that wants to step forward and run the Proven Care initiatives. And we're going to talk about that in just a moment. I'll provide a little bit more detail. Fundamentally, they need to have the leadership skills to be able to lead through a process improvement methodology. They also need to have that clinical credibility amongst their own peers. And, I would say that those are, fundamentally the key components to who would lead this initiative. And again, we'll talk a little bit more about that in just a minute.
Thank you, Catherine. Now back for our presentation.
All right. Catherine, you're up.
All right, great. Well, good afternoon, everyone. It's a pleasure to be here. We're always excited to see so many organizations and so many individuals who are excited and interested in bundle payment. As Ray had mentioned before, we've been working at bundle payment for some time. Geisinger started this actually in 2006. And the first bundle that we actually did was in Cabbage. And over the years, as we've continued to expand the program at Geisinger, we took on the position of being a facilitator convener with CMMI. And that's really, at the beginning, Ray introduced me as having had the opportunity over the past few years to work with close to 40 organizations. You know, we've seen, as we've sort of watched these organizations approach bundled payment, we've seen some consistencies around those elements that contribute to success and also some of the challenges that folks have had. We've seen some consistency on both sides of that. And so today we're going to talk a bit about the strategies for success, and I'll talk a little bit about, provide sort of a cautionary tale about those that have struggled a bit. You know, I think in large part, as it says here, the government is leading the way and commercial is following, and we certainly are seeing that with the work that we're doing with the 38 non-Geisinger facilities that are either on the government side or working on the commercial side. You know, I think that the things that we see that are the keys to success are, you know, some of the standard things that we've talked about before around performance improvement, creating reliability, consistency, and all of that really leads to this predictability about costs. And while I talk over the next few slides, you'll see some sort of a consistent theme to that. You know, the concept of combining forces and really forcing the issue of integration and accountability is really a solid component of bundled payment. When you take on bundled payment as an organization, there are a couple of approaches that we have seen. One approach is to try to run bundled payment purely through your contracting folks and your finance office. Those have been the folks that we have seen as truly stumbling. If you're going to commit to taking on bundled payment, we encourage a full commitment, and that means really approaching this care redesign piece. When you embrace the care redesign component of bundled payment, you're really putting folks on notice that this is not just the next thing or the newest thing, or, you know, sometimes I used to remember my hospital days, we would call it sort of the flavor of the month. This is actually a new approach to delivering care, and it really aligns all of the stakeholders around care delivery. And to this final point here on the slide, when we think about the stakeholders and we think about who those stakeholders are, they're not just the folks in your own, you know, sort of your own four walls. They're outside of perhaps your acute care facility, but for certain they are your post-acute partners. And your post-acute partners, what I've noticed over the past 3 years, is they look to the acute care for direction in terms of, how do I do this? How do I work through bundled payment? What are some of the things that we need to think about? On the acute care side, what I see is sometimes some reluctance or hesitancy to step forward and to have those kinds of difficult conversations. So as we look at proven care, what is proven care? Let's talk just a little bit about what it's not. It's not a top-down approach. It is a physician-led structured approach around performance improvement. As I mentioned earlier, a moment ago, someone asked a question around how is the clinical lead selected for proven care. As I mentioned, it's got to be somebody who wants to do this work. It has to have someone who has clinical credibility in the department. This process improvement approach has been tried and true at Geisinger, and it has been extensible to other delivery systems. We've now done this with a number of other organizations, and they too have found it to be transformative. The foundation of the work, I would say, truly rests with this clinician-led improvement team. And the pure work really comes from identifying best practice elements. It's one thing to say to your providers, be different in how you deliver care. It's quite another way to say, we're trying a new bundled payment approach, and here is a way to step through that. It also incorporates looking at Class 1 and Class 2A evidence from a literature review to truly support each of the specific bundles. We think about how do we redesign the workflow so that we eliminate, we automate, delegate, incorporate, and activate, and truly push standardization through. At Geisinger, we think every patient, every time as we put together this approach. It is consensus-driven. It's not a tacit agreement amongst our physicians. They truly, we say they stack hands in agreement to what the best practice elements will be. So as we look at eliminating, what are we trying to eliminate? We look for opportunities to get rid of the non-value added work. Stopping those actions that are not evidence-based, not supported by evidence, and I talked about the best practice elements. If something is not showing up as a best practice element, we question whether or not that is truly adding value. And as we all know, non-value added work, right, it leads to inefficient and costly care. So to the automation part, we look for opportunities to hardwire or create a trigger or a forcing function to make doing the right thing the easy thing every time for the patient. And then to the delegating point, we look at opportunities to take things that are currently being delivered by physicians and have these be delegated to a non-physician but appropriately trained staff person. At Geisinger, we also think about making certain that everyone is working at the top of their license. And so that sort of approach of delegating care delivery to someone that's willing to take that on creates, again, an opportunity to standardize the workflow. And then making sure that the patient, to the final point, is part of our team. They're part of their care team. And so we have patient activation, which includes having the patient literally sign their name indicating that they will comply with recommendations, whether this be medications, care approach, that we get a firm signature from the patient. So they understand there's something, as we all know, about signing something that is an important component. So to this slide, really, I think what we want to talk about here is that we're using proven care as an ongoing methodology. It is this multidisciplinary clinical team. The best practice elements drive the work. We integrate them into everyday practice, and we are very much a hardwired organization. And so we optimize our electronic health record to make sure that, again, it's a forcing function that pushes, again, doing the right thing for the patient every single time. This isn't to say that a physician can't elect to not do a particular best practice element. They can, but they do need to document why they perhaps have deviated from what has been agreed to within a particular service line. I think that if we move to the next slide here, thank you. So at its heart, the proven care approach has 6 components, and this is a high-level output of what those components are. It's really about identifying what's your current state, documenting the appropriateness of care. As I talked about before, looking at level 1 and 2A evidence to be able to determine whether or not this aligns with what your physicians have agreed to. Then looking at how do you redesign the care that you do on a regular basis? How do you build that in, again, creating forcing functions to make sure that this is embedded into everyday patient flow. I've talked about the engaging patients and families. At the end of the day, for bundled payment, using this approach, what you're hoping to get to and what you should get to is consistency around the delivery of care, which provides consistency around pricing. And so this really leads very well into creating that package price for the episode of care, and then eventually transferring that risk and its financial effects over to preventing complications. Again, we've got this upside down incentive system, right, within our current system. And so how do we start to drive out some of the reverse incentives that we have? And I think Francois will be talking about that in just another moment or two. If we can move to the next slide, I just have a quick case study about an organization that we've worked with. And this has just been a fascinating group to work with. They started with us about a year ago, actually. They had come for a site visit at Geisinger, had connected with one of our orthopedic surgeons, Dr. Michael Sook, and Dr. Sook encouraged them to start thinking about CMMI and bundled payment, and there our relationship was formed. They initially started working with us around, they were physician group practice, as it says here, started working with us around the CMMI initiative. They were very, I would say, bullish in terms of their feelings about bundled payment and its direction from a long-term strategy. They had an acute care partner they worked very closely with. They tried very hard to socialize the strategy with that acute care partner. Unfortunately, they were not as enthusiastic about bundled payments. I would say a little bit on the lower end of the adoption curve as it relates to bundles. And I think the acute care partner recognized that, this is the direction it's going in. However, they weren't quite ready. Even though the PGP had sort of thought about, well, where do we think we have opportunities looking at the data? They did a very thorough data review of the CMMI data and identified where they thought they had some opportunities. Ultimately, because they didn't have that engagement with that acute care partner, they did not go forward with CMMI, but decided instead to start to pursue commercial bundles. So at that point, we actually did the analytics for them, helped them identify their opportunities. They ended up identifying that they thought they could move about 30% of their current inpatient procedures to their own ASC. So, just a terrific strategy that they have all been able to, I think, gravitate towards as a leadership team, very solid, very consistent in terms of what their next steps are. An exciting organization to watch, and in spite of, perhaps not an overly enthusiastic partner, they found a way to continue to roll forward. Next slide, please. Great, and actually at this point I'm going to turn it over to Francois, and we'll take questions afterwards. Thank you.
Thank you, Catherine. So in furtherance of what both Catherine and Ray have discussed, what I wanted to address are a few issues related more broadly to payment incentives, and then in particular how it relates to things like bundle payment and encouraging providers to improve care and affordability. So as our organization is focused almost exclusively on trying to improve both incentives for the supply side, i.e. physicians and hospitals, and the demand side on patients, one of the ways in which we've approached our work is to systematically think about what is today causing negative incentives or incentives that might reinforce behaviors that we don't want to see reinforced, and remove those. And so, as the slide mentioned, the golden rule really is do no harm. In other words, design something that minimizes bad incentives, because it's really, really, really hard to do good things in any organization when you're encouraged. And it's not necessarily to be bad, but when you're encouraged essentially to have a behavior that's other than the one intended. And a good example is, and I know this was a question earlier, about work RVUs in hospitals and health systems, which are in practices that are still prevalent today. And so as the organization, i.e. the practice, the health system, the hospital, moves to contract with public or private sector payers on value-based payments, whether it's global arrangements like in accountable care organizations or tighter arrangements such as bundle payments, if you're continuing to encourage all of your clinicians to simply produce more units of service, then that's an incentive that goes against what the organization itself is trying to achieve with the payers with whom it contracts. And so you're creating inherently a potential for conflict where the organization is trying to accomplish one goal, but encouraging the clinicians in the organization to do something else. So designing incentives is a complex process, but the first rule is really to minimize bad incentives. And it's not the same thing as maximizing good incentives, and there's a fair body of literature that suggests that the carrot approach, i.e. dangling something as a reward towards the end of the year, is the way of motivating good. Most people think it's a way of motivating a certain behavior. It actually doesn't work as well as simply reducing negative incentives. So an example is, and Catherine just talked about the Medicare bundle payment for care improvement, which is a national program by Medicare piloted with thousands of providers, and in which one of the formula that they use is to establish a baseline performance or baseline price and the providers who accept the price are then put at risk, i.e. if they exceed the price, then they have to pay CMS. If they stay underneath the price, then they get a check from CMS. And that's very similar to most bundle payment projects or pilots or initiatives that we see in the commercial sector, except in the case of Medicare, they're moving the goalposts. And what does that mean? Well, it means that at the end of the year, at the end of a performance period, you think that you've achieved a certain result, but in fact, the government comes back or the payer comes back and says, well, everyone else improved, so we decided to move your target. And so you thought you had done okay, but you didn't. And it just violates most principles of incentives, because if you're setting a goal and whether it's achievable or not is another story, but if you're setting a clear goal, then performance is judged against that goal, and you shouldn't introduce another incentive which is going to deteriorate the primary incentive that you're trying to institute. The second one is you're not minimizing bad incentives when you're encouraging any type of gaming opportunity. So gaming opportunities are any attempt to move around diagnosis codes, move around patients, adjust the severity in some fashion or another in order to win at the edges of a program. And so anytime you have an incentive program that inherently encourages or doesn't discourage the potential for anyone to look at how they can potentially play the game or move around the dials in order to win, as opposed to simply focusing on doing their jobs as professionals, then you're not minimizing bad incentives. There's a lot of that going on. And then finally, you're not minimizing bad incentives when you fail to hold providers accountable for downstream care. And so what does that mean? And it goes to the point raised earlier, a question raised earlier about a period of warranty. So if you think about most bundle payment programs, they are focused on a specific period of time. And let's say it's an inpatient procedure and even an acute stay. And when the patient is discharged, the clock keeps ticking. So in other words, the period of performance includes the period post-discharge if it's a hospital-based event, or beyond just an office visit or a series of office visits, so that what happens downstream is in fact taken into consideration. And the reason why that's so important is because if you don't do that, then you're not solving the care management problem. All you're doing is widening a little bit the scope of what's being done today in fee-for-service, but you're failing to encourage professionals to work collaboratively around the care of a patient. So it's really important to think about how these issues interplay and to, again, solve for minimizing bad incentives as opposed to constantly thinking about what's the carrot that I can put out there. Next slide, please. All right, so for us, when bad incentives are reduced, and we see this play out in almost all of our implementations, is that providers end up by doing what they're supposed to be doing, which is they're clinicians, they're trained, they spend a big portion of their lives going to school to learn a profession and apply that profession, and that's what they do. And one of the very important triggering mechanisms ends up by being the quality feedback, and Catherine talked a bit about that. So in other words, if you stop the distractions that are driven by the payment model that encourage or don't discourage a certain behavior, i.e. increasing, for example, the intensity of just services being done willy-nilly, and then you really allow the provider to focus on the clinical care, what really becomes a triggering event that helps them improve is if you have rapid feedback loops on the actual clinical work that's being done, and that allows the clinicians to understand how well they're doing in managing patients, what's happening downstream, what can they do to modify their care patterns in order to improve quality. They figure out really quickly how to better manage the supply chain as well. And some examples we have from across the country include physicians calling device manufacturers and really negotiating better deals, or looking at what happens post-discharge of a patient from a procedural episode, and questioning, for example, whether or not all patients should be discharged to a skilled nursing facility as opposed to different options that might exist. A lot of providers are also looking to engage directly with employers. Why? Because there's an increased recognition that sometimes the incentives, or if you will, the desires of an employer and its employed population is really to work collaboratively with clinicians around the care of patients, not in an insurance game, but really in a normal routine way of maintaining a healthy workforce. So the triple aim actually does work when the incentives are designed appropriately, and when the clinicians really focus both individually and throughout the organization on true care management and care redesign. What's often happening today is that under the auspices of the triple aim, you see very significant market consolidation for one purpose only, which is controlling the market, because there's a fear that you're going to have a lot of disruption when payment moves from, and there is increasing disruption as payment moves from normal fee-for-service to value-based payment. And finally, I think the other exciting element that we see happening is that payers are encouraging their plan members to shift to high-value providers. And that's going to continue to happen at a higher and faster rate, mostly because private sector commercial payers are deploying transparency tools. You now also have transparency tools that are being deployed at statewide levels. All of that is fundamentally creating a market for healthcare services, and that market is moving to a lot of disruption. And so we see physicians and physician organizations getting together in far different configurations than the traditional big box. Why? Because they understand that they can respond to consumer needs and patient needs a lot better. So what we see in happening when incentives do work, i.e. We minimize the bad stuff, is that providers feel absolutely in control of their destiny. And I get emails almost weekly from nurses and physicians whose lives have changed because they're no longer worried about quotas. Patient experience of care massively improves because patients suddenly feel that not only are they engaged, but they're engaged in collaboration with their providers. And then defects, what harms patients, what harms the systems generally, are systematically being eliminated because true care redesign can function. So it's just, I can't emphasize enough, take the bad stuff out, start with that, and then a lot of the rest of this works itself out.
All right, thank you, Francois.
Thank you, Francois. We will now take a moment to address a couple questions from the audience. This would be a good question for Catherine. An audience member would like to know, what would you recommend for a provider organization aligned with a payer to do this kind of work? Can you go through step by step what is done?
Great question. So there are really two approaches. So let me talk a bit about the commercial approach that we use. First of all, it's always exciting for us to see a group want to step forward and take this on. It's new work. It's absolutely exciting work, and I think everyone who's been involved in Successful thinks it's directionally correct for sure. So essentially, we've taken the claims data and we analyzed a historical group of data from an organization that will show opportunities. So we really look first at all of the claims data that we bring in. We decide on where is the opportunity. And then also we turn back to that organization and ask them where they think, for example, they have some clinical willpower to be able to redesign a particular component of care. And so as we do that, we then deploy the proven care concept that I just talked a bit about. Again, identifying those best practice elements. And let me just say another thing about the best practice elements. These tend to be those things that essentially you would fail your oral boards on if you got them wrong. So we start there, using the proven care approach to accelerate redesign. And then from there, it focuses into where are the pricing opportunities and how would this be administered going forward. I mentioned at the beginning, I think, proven care has a start date. It doesn't really have an end date. It does from the intensive upfront work, but in terms of monitoring and making certain that you're not slipping back into some prior behaviors, that's the important work of proven care. So together, all those things provide the bundled payment opportunity from both the finance side, but also from the clinical redesign side.
Thanks, Catherine. The next question from our audience is, what do you find is the best way to get buy-in from the physician? We have many small practices that say they have no time to do the extra work, even though we are looking to pay them for it.
Okay, another good question. Great question. In fact, when I had started at Geisinger a number of years ago, I had asked the very same question. And I will say that at Geisinger, I think it's known that this is the approach that is used. Having said that, though, if you have a large service line, say like your cardiologist, for example, you tend to select a representative group of physicians. So it's not every physician, but a representative group that will step through that. We do provide some protected time as well for the physicians to participate in this, particularly the chairmen to be able to be part of this, or the champion to be part of the process, and that would be the clinical champion. So we do provide some protected time as well. But I think that over time there's been such a strong response to the proven care approach that I think that culturally it has been accepted and well received. That doesn't mean we have everybody is always excited, but I think that they understand that the outcome of this is a very positive thing for the patient as well as the clinicians.
Yeah, I think another area that is compelling is if you're the sponsoring organization and you could bring some information, some data that's been organized and structured so that for the first time for many physicians, they're able to see, what an entire kind of complete episode of care and all the experience around that looks like. It's not a lens that most providers are familiar with. So there's part of bringing folks along is that, that early stage education and giving folks some time to understand what, not just what the physician component is, but what the total cost of the episode is and how many different players or suppliers are involved in that episode, and to begin to sensitize people to not only the degree of variability that exists, but how much of that variability the physicians themselves can influence or affect. And so part of bringing on, if they're not employed physicians, but they're affiliated in somehow, to bring them in and share information and just give folks some time to get grounded in the fact base, the basis for moving forward has huge upside. It kind of de-escalates or reduces the abrasion that historically has been adversarial, and it begins to help everybody focus on the overall problem of not just the extreme variability, but it's pretty readily apparent how much opportunity exists for whether it's avoidable complications, readmissions, how many different providers are involved in the care. I think that begins to build some trust and some common understanding of the problem at hand.
Ray, and I'll just add to that I also think that it accelerates the overall approach, and having proven care behind it accelerates towards getting to the goal of working through the bundled payment exercise. And so I think that there's definitely been some strong support at Geisinger for proven care.
Perfect. Thank you both. We will now return to the presentation, and there will be more time for question and answer after it's over.
All right. So some closing thoughts, and maybe it'll provoke some additional questions or inquiry from the audience. So this tsunami that we're beginning to live through is going to be a pretty long run. I know that the government has said that they want to be at 50% by 2018 and 80% by 2020. There's a fair amount of ambiguity about what that means. I think what's more telling about the rate of change is where specific states, state of Ohio, some other places, they've laid out their specific 5-year roadmap, and it's pretty clear that they're going from 7 to 14 to 28 episodes. There's a clear escalator up on the amount of the percentage of the spend that's going to be framed within a value-based bundle payment arrangement. I think the other accelerant to this is that some of the states are either forcing or looking to collaborate with the commercial insurers to say, if we're going to do this, we've got to have it be in a sustainable, consistent way. Why don't we adopt common understanding, some convention around what defines an episode? How do we deal with outliers? How do we deal with attribution? How do we address certain aspects that have to be in place? Because if every carrier does it a different way for a provider, then the provider is not going to be able to move forward. It's too hard. It's too complicated to administer. So this need to establish convention in the marketplace around the definition of episodes, how they're assigned. When and in what instances do you either call out extreme outliers or deal with some appropriate math to acknowledge that it's an outlier, but not totally eliminate it from the equation. So there's a real need, I think, that we're going to see for folks to rally around, convention and common ways of doing things and learning. As everybody's going through this process, we're going to learn a lot. So how do we share the successes and communicate it through webcasts like this, but also what didn't work and why didn't it work, so we can learn from others. I think the other is that as the evidence comes forth and people are publishing and showing outcomes, I think that's another area where your organizations could go back and say, listen, we don't have to invent this ourselves. Why don't we leverage and find people out there that have done this before? Even if it's relatively new, it could be an accelerant to leverage kind of the growing body of evidence around how to do this the right way, as well as understanding the downside, as Francois touched on, of the incentives being misaligned. So the economics drive the motivation, but the real sustainability of this is not, the insurers will figure out how to pay claims under this arrangement. They'll figure out how to do benefit design and benefit administration. The real hard work is the ground game of the value re-engineering, of the care redesign. And I think we're just at the very beginning stages of really getting after that. I think the other part that is important to touch on here is a lot of folks have, they've jumped into BPCI. They're in this hyper learning, hyper innovation mode. They've brought in third parties that will, hedge off. They'll provide the reporting for free. They'll figure out the risk and the arbitrage, and they'll take on all the post-acute care under capitation or whatever. And the problem with this is that while there's savings to be had, a lot of providers are not aware that when they sign up with these different third parties, they basically give away, if not all, a major portion of the upside potential. So they'll go through this hard work, this redesign, get everybody motivated and mobilized. And at the end of the day, they might have done a terrific job, and there's no consideration, meaning dollars, that are available to distribute out to the different, to the physicians, to the hospitals, whoever. So, one of the things that we wanted to, just kind of raise the awareness of is understand the contract you're signing, because the third parties that are jumping in, they do help. But if you do the math, you'll understand that many folks have given away almost all the upside. And the last piece to touch on here is the chicken did come first. If everybody through their own goodwill and doing the right thing, we could have done the redesign 20 years ago, 15 years ago. the reimbursement and the fear that comes from changing how everybody is compensated comes first, and that's where we're at right now. Is that the market's moving, and so there's got to be a balance, because we've lived through in the 80s, shifting the risk too fast. The accountability without control, results in failure, and so the balancing act of moving quickly, but making sure that the provider side has access to the data, is able to understand not just risk, but what processes they have to put in place that allow for scalable kind of systemic care redesign are going to be essential for this to play out in a favorable way. There's going to be roadkill. There's going to be failure. But I think what we need to do as an overall industry is identify and amplify the successes so others can learn from it. And we'll open it up to any more questions.
Perfect. Thank you, Catherine, Francois, and Ray for a very informative and enjoyable presentation. We'll now begin the final Q&A portion. Just a reminder for our audience, you can submit any questions you have by typing them in your control panel in the space labeled "Enter a question for staff" and clicking send. We have a few questions already, so our presenters will attempt to answer as many questions as they can during the time we have. They will follow up on questions they do not have the opportunity to address. We have a question from our audience member who would like to know, for subspecialty providers, how do you see these independent practices, components of the concept of a bundle, being paid for their services?
Who wants to take that? Francois, do you want to talk about what you've seen in the market?
Yeah, so and this question often comes, and I think there's another question here also about states like California that have corporate practice laws that prevent ownership by hospitals or health of physician practices, and all these questions kind of relate to one another in how does the money flow if you have a bundle payment arrangement, and there are various ways of doing it. So in the federal program, the Bundle Payment for Care Improvement, there are what are called convener awardees who act as, think of them as financial integrators. So they're non-provider financial integrators. And they take the bundle and they take, or they take financial responsibility for the bundle, underlying the normal payments, fee-for-service payments, continue to flow by Medicare to the providers. They get regular reports on how well they're doing, actual compared to budgeted price or negotiated price, and at the end of the reconciliation period, there's a true-up where there's either money owed one way or the other. So the only issue that you have to resolve is how are the losses or gains going to be divided between the various parties participating in the bundle payment arrangement, and that ultimately ends up by being a negotiation. There are pilots where only the physicians are participating, even in procedural episodes, and so the surgeons are responsible for all of the upside and or all of the downside. In others, it's a collaborative approach between the surgeons and the hospitals, and there's an agreement around how the upside and downside is going to be shared, 50-50, something different than 50-50. But here's where you don't violate any of the existing regs and rules. It's that there's no money changing hands between one practice to another practice, one hospital to a practice, etc., because the financial intermediary, whether it's the convener awardee in the bundle payment for care improvement, or in the commercial world, it's called a health plan or a third-party administrator, is the organization that ultimately is responsible for parsing out the upside, if there is an upside, or collecting the downside. So the only issue that needs to be resolved and negotiated between the providers is what is each other's or each one's respective share of the gains and losses. And you need to get over that relatively quickly, because what's important after that is collaborating in the management of patients. So it's actually not that complicated. And most people think of bundle payments or other payments like this as someone's going to get prospectively paid, and then someone is going to then have to re-divvy up the money. That's really not the way it works. It's really a contract. People agree on how much and who shares in the upside or the downside, and then the financial intermediaries, i.e. the health plans, do most of that accounting work in the background.
Right. And I think what Francois is focused on is on the claim or the reimbursement side. Underneath that, a number of our clients and a lot of other folks are looking at, what's the cost of delivery? So if it's orthopedics, and you could move from 17 different prosthetics to 3 and get predictability about the underlying cost of the delivery of care. There's also, that can get worked into the math as well, so that there's both margin and change in the overall total reimbursement. Those are both vectors that people need to capitalize on.
Perfect, thank you. Our next question is for Catherine. If I'm a provider organization and have started talking with a payer about bundled payments, what approach have you used or would you recommend to move this work forward?
So actually, I think that's probably a good one for Ray.
So clarify, is it the provider going to the payer, or is it the payer approaching the provider?
I believe it is a provider organization speaking with a payer about bundled payments.
Right. So got it. I think that the key is that to start off with is sharing and looking at the same set of data and making sure that both sides have a common set of experience, and that there's a good buildup of trust. Most of the time, the relationship between a payer and a provider is somewhat adversarial historically, and so building the trust and sharing the data and understanding what's in that data, that becomes the basis for not only getting an understanding what the opportunity is, but it also becomes the basis for the contract. And that those contracts have to work for both parties for it to be a positive sum game over time. So the key, I would say, is to start with the discussion and a real thorough, complete, transparent review of the data. And that part is usually you get a bunch of reports, and it's a foreign language if you're a provider. You're not used to seeing the data the way a carrier looks at it. I think the other thing that the provider needs to do is they need to take that data in-house and be able to begin to understand it or translate it to what comes out of their systems, so that they could understand how that claim data links into and ties back to what's within their own system, so that they have a way to begin to appreciate what's happening in their four walls versus what parts of these episodes are happening beyond their four walls, that they're going to have to get a sense of who they need to affiliate or collaborate with in these type of arrangements.
Perfect, thank you. We have time for one more question. Getting to bundle definitions is challenging. What is the best method to efficiently arrive at acceptable definitions?
Yeah, well, that's a good softball for me. And this is Francois. And so at HCI3, we have published our definitions as open source definitions. Anyone can get them in all their gory detail, and we update them on a regular basis, and they can be found on our website at www.hci3.org.
Perfect. Thank you, Francois. That's all the time we have today. I want to thank again our presenters for their excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars.